At the outset, I would like to thank the organizers for providing this wonderful opportunity to speak on this interesting case, recurrent fevers, no apparent infections in a boy, an eye-opener. This is a 3-year, 8 months old boy, Master V, who was first seen in March 2019 when he presented to us with recurrent fevers from 8 months of age. Reviewing history, one could see that this boy was unwell from the age of 8 months, had recurrent episodes of fever, almost one episode of fever once in 2 months to begin with, short lasting episodes, and this was associated with blood in stools. This boy was investigated as a probable case of cow's milk protein allergy in the first 2 years of life. He remained well in between for 6 months and subsequently started having recurrent fevers almost every month, lasting for 5 to 7 days. And these were associated with oral ulcers, and some episodes were associated with cervical lymphadenopathy. Naturally, this child had received multiple courses of antibiotics. It was in February 2019 when the child developed a prolonged episode of fever, enlarged cervical nodes, and was hospitalized elsewhere where he was investigated extensively. As you can see in the previous episodes, the counts essentially were normal. There was thrombocytosis and there were records of high ESR and CRP at one occasion while it was normal on the other occasion. However, it was in Feb 2019 when the child was investigated extensively and these were the reports. This child had neutrophilic leukocytosis, thrombocytosis, high ESR and CRP, extensive workup for infections including brucella, tuberculosis, HIV were negative, repeated blood cultures were sterile. The child underwent a bone marrow biopsy which was reported normal, and this child was empirically treated with antibiotics and got better. He was also investigated for a probable immune deficiency. The immunoglobulin profile essentially was normal. The nitroblue tetrazolium test, which we do as a screening test for chronic granulomatous disease, was reported normal. A PET-CT which was carried out at that point of time showed metabolically active supraclavicular and cervical nodes with probable necrosis. That was the report. An FNAC of the cervical node was reported to have necroinflammatory lesion, and it was only after the discharge and follow-up when the child was all doing fine, the FNAC culture showed Pandoria species, which was considered to be a contaminant at that point of time. The past history was not significant. There was no history of pneumonia, ear infection, or oral thrush, no history of rashes, no history of any abscess formation, skin or deep-seated. Developmentally, this child was normal. He was immunized for age, and family history at that point of time, this child was born to a non-consanguineously married couple and was the only child in the family. So the database, a 3-year, 8 months old boy, no significant family background as of now, recurrent episodes of fever, workup for infections extensively negative on most occasions. We thought, could this be a probable periodic fever, because this child would develop episodic fever every month and had high ESR and CRPs, something like a FAPA syndrome. And we said this child needs further evaluation. The mother was counseled for regular follow-up and further evaluation. However, as is not unusual with chronic cases, this child was lost to follow-up. A year later, there was a twist in the tale. And what was that? We had a 3-month-old boy who presented to another hospital with fever and rapid breathing and was diagnosed to have pneumonia. He also had BCG site swelling and enlarged nodes, and he is the younger sibling of Master V. Now this child, since he had BCGitis, the treating team rightly thought of an immune deficiency and investigated this boy, and what they noted was in the younger sibling, who is Master H, the DHR, the dihydrorhodamine test, came back abnormal. As you can see in this picture, in the control, these neutrophils clearly show this is unstimulated and this is stimulated neutrophils. They clearly show a shift to the right, which is not seen in Master H. And so he was thought to have chronic granulomatous disease and was referred to our unit. And when we investigated the family, not only Master H but even Master V had an abnormal DHR, confirming both of them had chronic granulomatous disease. The mother was investigated. As you can see in the mother, there are two pics. Some neutrophils have shifted to the right, some haven't, indicating that she is a carrier for X-linked chronic granulomatous disease. Genetic testing in Master V confirmed the mutation in CYBB gene, again confirming X-linked CGD. So I sat with the mother, asked her in detail to again inquire her mother, is there anything significant in the family? And when we got this pedigree, we were surprised. As you can see, this is the index child Master V, the Master H. This is the mother who is the carrier, and the grandmother actually had two sisters. The The older sister had lost two boys at younger age before the age of 10, and other children were alive. And the younger sister had lost one boy. And in fact, the cousin sister of the mother has a boy, the maternal aunt's son, who is diagnosed to have spinal tuberculosis and is currently at Vishakhapatnam. He's a 10-year-old boy who is having a spinal tuberculosis and discharging sinuses, as you can see from this picture. And when we investigated this boy and her mother, you can see the mother again is a carrier on the DHR, whereas the master A in Vishakhapatnam is a case of chronic granulomatous disease. So now it turns out that this family has multiple members with X-linked CGD. So what is chronic granulomatous disease? A disorder characterized by defect in phagocytes, wherein they are not able to kill intracellular organisms. These children classically present with suppurative lymphadenitis, non-resolving pneumonia, lung abscess, liver abscess. Many of them have colitis, hepatosplenomegaly, and hypergammaglobulinemia. However, in the index case, there were recurrent fevers, no apparent or obvious infections, no suppurative infections. Were there clues? Could we have diagnosed this child early? High ESR and CRP was there. Blood in stools was there. That means this child had colitis, and FNAC of the lymph node culture, which showed Pandoria species, which at that point of time was thought to be a contaminant, probably was a significant organism, because this is an unusual organism being reported in immunocompromised people. Lessons learned from this case. NBT, which we used to screen the first case and which missed the diagnosis, is a semi-quantitative test and is observer dependent. DHR has better sensitivity and specificity and is the test of choice for screening chronic granulomatous disease. DHR in mother can show two peaks, and if it does, she is a carrier for X-linked CGD, and this is what is very much interesting part of DHR compared to NBT. CGD can present with recurrent fevers and no obvious or apparent infections. The more you dig into the family history, the more you get. Thank you. I would be happy to take up questions.